due to the strong genotype-phenotype correlation of almost 100% that's seen in renal recessive diseases, just wanted to talk about, again, how important it is that these patients get seen by a geneticist and by a genetics counselor and by a nephrologist. Especially in single-gene renal disorders, it's important to know the diagnosis that allows for prenatal diagnostics, can precisely reveal the primary cause of the disease. There's high diagnostic and prognostic value to this, and this really allows, in pediatrics especially, to have us undergo personalized medicine for our patients. Since the recessive mutations, like I said, conveys almost 100% risk that the patient will develop disease by the time they reach adolescence. An example of this is ARPKD. So there are a lot of overlapping symptoms and signs between the genotype and the phenotype, and this can be used to help inform prognosis and management. So for example, genetic testing can help distinguish between Alport syndrome and the related milder disorder, thin basement membrane disease. Both of these hematuria nephropathies do result from mutations in the COL4A3 to 5 genes. Despite such a high genetic and phenotypic overlap, the two conditions nevertheless differ markedly with respect to clinical outcomes. Alport syndrome patients really have a more severe disease with extrarenal manifestations such as audiologic or ocular deficits, which we discussed earlier, and they can progress earlier to end-stage renal disease, requiring a transplant and/or dialysis. Importantly, the genotype level mutation can also help predict phenotype. So in general, biallelic COL4A3 and COL4A4 or hemizygous COL4A5 mutations result in Alport syndrome, whereas heterozygous COL4A3 to 4 mutations result in thin basement membrane disease. Thus, genetic testing can provide valuable prognostic information and guide further workup and management, such as informing the appropriate timing of transplant referrals and pursuing evaluations for visual or auditory symptoms among Alport syndrome patients. So shifting a little bit towards adult monogenic kidney disease, currently about 30% of CKD with the onset less than 25 years can be attributed to an established monogenic cause. However, there's significant variability in the reported prevalence of monogenic causation depending on the underlying actual CKD phenotype. And so Mallet, in 2017, did a study using a gene panel of 207 genes. And these genes were sequenced in patients that had a familial nephropathy, and a monogenic cause was found to be detected in about 43%, about 58 of 135 families. So using this curated panel of genes, they could assess that there was a substantial proportion of these patients and these families primarily made up of adult CKD patients that ended up having a genetic cause for their disease. In another study using a whole exome sequencing analysis, Lata et al. In 2017 demonstrated that in 20% of adults with CKD, a causative mutation in a known monogenic CKD gene could be identified. Their cohort consisted of 92 patients with CKD attending a tertiary nephrology center in the United States, adults presenting with CKD with one of the following diseases that are listed there: glomerular disease, tubular interstitial, undiagnosed hypertension, or the developmental disorder, were submitted for whole exome sequencing analysis. And the cohort was enriched for patients with either a family history of CKD or undiagnosed CKD, like I said. So interestingly, using this method of whole exome sequencing, this actually led to the reclassification of diagnosis in 6 of 19 families, while this actually established the diagnosis in 7 of 19 families that were initially thought to be just unknown. So genetic testing can help in all of these regards in terms of actual precise diagnosis, confirming diagnosis, reclassifying, especially reclassifying from a family or a patient that is thought to have an undiagnosed mutation. It's quite important for them. So this is just another study that was done in 2020 by Hildebrandt's group, which looked at many different studies and the diagnostic yield that was being reported from adults versus pediatrics in terms of molecular genetic analysis for the diseases listed there, nephrotic syndrome, CACIC, chronic glomerulonephritides. Molecular genetic testing was performed by exome sequencing, or a gene panel sequencing was done. For disease subgroups with more than 2 studies, the median diagnostic yield is listed there, and that was used. Interestingly, there wasn't a huge difference in the number of patients that were diagnosed in adults versus pediatrics for some of these subtypes. And then this is just another study that was done out of Ireland, which looked at using whole exome sequencing in 114 patients that included 138 affected individuals with CKD. Affected individuals were mostly adults, and then they had a positive family history. Quite a number of them had extrarenal manifestations, and some had family history, some didn't have any family history. So it was a big conglomerate of different types of patients and families. They detected a mutation in about 37% of these families, and there was also about 70% of these families were found to have extrarenal features. So this is also shows that if you look closely at the slide, on the right-hand side, it shows that there's actually no difference in the rate of genetic diagnosis in individuals with a childhood versus adult CKD, which is very interesting. So a lot more still needs to be done in terms of research in this realm. Just skip over that. Okay, so just going quickly into specifically steroid-resistant nephrotic syndrome and the genetics of it. About 30% of FSGS is thought to be steroid-resistant and can present with recurrence in kidney transplant. The most commonly known genes are nephrin and potassium, which are listed here, which can cause congenital nephrotic syndrome and non-familial childhood steroid-resistant nephrotic syndrome. So genetic form is important to know because it can help with predicting progression to ESRD and the likelihood of recurrence after kidney transplant. And it can also help with guide with treatment. So if you have a genetic form, most likely you're not going to respond to steroids, and you can try to prevent the patient from taking steroids and having all the accompanying side effects of steroids. So this is just a slide looking at the genetics of steroid-resistant nephrotic syndrome. There are 3 different studies done in 2015, 16, and 17. All of them use different curated gene panels looking at the genetics of nephrotic syndrome. And you can just see that there is just a much higher rate of a genetic cause to be found in the pediatric kidney disease patient versus in adults. So in terms of histology and genotype correlation, like I said before, there can be actually quite a poor correlation between the histological findings and the underlying actual genotype, which I discussed earlier with Alport syndrome. There's a huge phenotypic variability with the collagen genes, especially COL4A3, 4, and 5, which can have nephritis that may phenocopy as nephrosis. So the 2 studies that were done here that are listed with Sen and Mallet show that adult patients with nephrotic syndrome are often found to have mutations in an actual collagen gene. So this is just important to know in terms of therapies and predicting recurrence in the future for after transplant and looking at extrarenal manifestations in these diseases. Quickly turning to next generation sequencing. NGS, or next generation sequencing, is also known as massive parallel sequencing. It's an innovation that enables rapid and relatively inexpensive sequencing of multiple genes. And there's 2 different types of next generation sequencing that we like to use. Whole exome sequencing, which targets all coding regions in the human genome, and whole genome sequencing, which targets just the coding and the non-coding regions in the genome. And so the diagnostic yield for using NGS in pediatric kidney disease is quite high. Usually, so NGS has been listed as one of the reasons why we now know that copy number variations and neurocognitive defects are associated with kidney disease in children. So a lot of children have developmental delay, and this is thought to be due to copy number variations, and it can also cause renal dysplasia and hypoplasia, CACIT of all different types. And the copy number variation has only really come to light with the advent use of next-generation sequencing. Next-generation sequencing can also be helpful in diagnosing FSGS, renal ciliopathies, and MPGN or atypical HUS. It's, for example, the discovery of variants in the DGKE gene, which encodes intracellular kinase expressed in the endothelium, platelets, and podocytes among individuals with MPGN and or atypical HUS, has really helped us to better understand how signaling disruptions lead to endothelial damage, complement, and podocyte dysregulation.